Hello, today we are seeing our third part of the series of courses on the techniques for bicoronal synostosis, and we are seeing now the fronto-orbital advancements for brachycephaly, which is the standard technique in most cases, but in very young children, we may need other techniques which have been described before. So now we are seeing the classical fronto-orbital advancements for brachycephaly. First, we shall see the pathological anatomy in bicoronal synostosis. We have already seen the cloverleaf pattern. So we are seeing now the turicephalic pattern, in which case the forehead is wide, tall, flat, and quite ugly, we must say. And this is a typical appearance. And you see that the orbits are very shallow. They look like a champagne cup rather than a champagne flute, as they should. And we also have the oxycephalic pattern, which can be treacherous because it is harmonious, but the head is too small and there is a risk of intracranial hypertension. Characteristically, the bregma closes last, so it gives birth to the clown's hat, which corresponds to the final closure of the bregmatic fontanelle. And as I said, there is a decreased intracranial volume, so there is a raised ICP, and these patients are at risk of becoming blind. So the pathophysiology, we have to remind that the function of the coronal suture is to allow the calvaria to grow. We see, a contrario, the function of the coronal suture by what we see in the bicoronal suture. We see that, in fact, the face is held back and up because the coronal suture functions as like in conch shells, the growth follows a logarithmic spiral, and the advancements and the lowering of the face are the results of the function of the coronal suture. So it leads to a restricted intracranial volume, and there are other causes of intracranial hypertension, especially because of the venous compression and also to the hydrocephalus, which can be caused both by the compression of the brain and compression of the venous outlets. So there are different causes leading to the intracranial hypertension. So now we are speaking about the fronto-orbital advancements. The aims are to increase the intracranial volume and to reshape the forehead. You see on the top right the art by Philippe Pellerin showing how the forehead and the bandeau shall be advanced and kyphosed. And as we see, we very often also do parietal bone flaps, which are also advanced to reshape the skull and to buttress the frontal bone flap to avoid it that it backs after the closure. And this is the aspect of what we generally obtain. And you see that the pattern of the correction follows the curvilinear vector of the growth by the coronal suture. So how do we do it? We do a frontal bone flap, and then we cut the bandeau. Here you see the different bone flaps which are cut, the frontal bone flap, the bandeau, and the parietal flap. And first we shall replace the bandeau in a kyphotic position so that it is advanced and kyphosed. And on top of this bandeau, we shall replace the frontal bone flap, which is often turned over 180 degrees. On this forehead can be also improved by opening it in the midline and replacing the half bone flaps with an overlap that would make the appearance of the forehead more round, narrower, and more good looking. Then we replace the parietal bone flap in advancement with a rotation, so it comes to buttress the frontal bone flap here, and you can see that the shape is trapezoidal. That means if we can adjust the shape to improve the transverse diameter. If we want to increase it, we cut the bone flap wider at the rear end, and if we want to reduce the transverse diameter, we make it narrower at the back end. So this is how we do the surgery. Here we have cut the frontal bone flap. We have cut the frontal bandeau. Then we have replaced the bandeau in a kyphotic position with the overlapping of the tongue of the bandeau with the fronto-parietal tongue behind. Here the suture is done with wire. It can also be done with absorbable suture, of course. And here we have replaced the frontal bone flaps on top of the bandeau, and we have replaced the parietal bone flap, which are advanced and maintains the reconstruction in good position. So the final construct can be fixed, like we have shown, but we have also possibility of a semi-rigid construct like this, because we have opened the greater wing of the sphenoid bone, so that the facial skeleton can be advanced by the thrust of the brain. We can do additional intervention during the same session. We can also do a craniofacial distraction. Here we have put the distractor during the same operation as we have done the fronto-orbital advancement, and this is the result of this advancement in this morphing image. And on the CT you see that the pharynx is opening very fast, and very soon the breathing will be improved. So this is the technique created by Philippe Pellerin with a pin which is put in place in the maxilla and attached to the distractor. So the result of this surgery, we obtain a volume expansion. This is an example of a late diagnosis in an 8-year-old girl who has been evaluated in neuropediatrics for a schooling problem. But you see that the head circumference is stagnating. It is at -2 standard deviations. And with fingerprinting on the CT scan, you see that her face is not very, it is harmonious, but you see that the forehead is retained back. And after surgery, the forehead is much more rounded, and the child is much better after surgery. So the volume expansion is shown here in this picture. You see how it is at the end in red, but and how it was at the beginning, and you see how it is expanded by this surgery. And on the right, you see that the increased volume has been measured at 60 milliliters. So it's significant. The result is not just volume expansion, it is also morphological correction. In this case, you see that this neurocephalic child has also anomalies in the face, which is retained backward, and you see that after surgery, the face is much more relaxed, and in particular, the eyelids and the nostrils have a much more harmonious appearance because the forehead has been advanced and lowered. So in conclusion, the fronto-orbital advancement is a standard procedure for bicorneal synostosis. It is practiced starting at about 9 months. It gives a significant volume enhancement, but also an important morphological improvement. And it also allows complementary correction of hyperterrorism and, as I showed, facial distraction for facial synostosis. I thank you for your attention. You can see more videos on the playlist on YouTube and more data on our website. See you next time.